I'd like to welcome Dr. Sarosh Khalid-Khan this morning to our last in an 8-part series that we've been doing on eConsults. She's joining us this morning to talk about child and adolescent psychiatry and questions that can appropriately be answered through eConsult and her experience using the service over the last couple of years. So welcome, Dr. Khan.
Thank you, Danielle. Thank you, everyone. I'll share my screen, which always makes me nervous. Okay. Okay, I don't know what's.
So it looks like we're seeing your Chrome screen right now.
Okay. Do you see it now?
Just coming up on the screen.
And you see the slides?
Yes. So
Okay.
Lovely picture of
All
mental
right.
health.
All right. Thank you. Welcome, everyone. As Danielle said, I'm going to talk about child and youth psychiatry. I'm a staff psychiatrist in the Division of Child and Youth at the Department of Psychiatry at Kingston Health Sciences Center. And for my disclosure, I just have a Department of Psychiatry internal faculty grant, which has no potential conflicts of interest with this presentation. So today the objectives are really to identify relevant opportunities in my specialty for the webinar, integrating eConsult into the practice of primary care providers and managing patient needs effectively through eConsult. So just wanted to start with the fact that there's an international shortage of child and adolescent psychiatrists, which has been ongoing for several years, and it's not going to remit any time in the near future. This slide just highlights the US total child and adolescent psychiatrists on the left side. There are about 10,600 total child and adolescent psychiatrists, and the number of children under 18 are around 74 million. And so there's about 14 child and adolescent psychiatrists for 100,000 children. And the average age of those child and adolescent psychiatrists are 52. So the shortage, more people are going to be retiring and less people are coming in to the specialty. And a few years ago, the Ontario Psychiatric Association, just a couple of years ago, put out this information that Ontario has also a big shortage, not just of child and adolescent psychiatrists, but also psychiatrists. And it's creating a huge crisis, all to say that capacity building in primary care is really, really needed. And really that sets out the work of part of our work as child and youth psychiatrists to help colleagues develop some of the capacity to treat young people for mental health in their areas. And wanted also to show what our status is in our division. We usually get, this is referrals for a year average, and a small section is for eating disorders, but the rest is really equal amounts almost for neurodevelopmental disorders like autism spectrum, high functioning, ADHD, learning issues, and a combination of all of those, and mood and anxiety disorders, in addition to self-harm, suicidal patients, just all types of mood and anxiety disorders under that. And the average is 48 referrals for a month, and it takes about 10 to 12 months right now for an intake appointment. We've been hit hard. All right, so sorry about that. Just wanted to talk about now my utilization data for number of eConsults in the past 6 months. As you can see, the utilization is pretty low. However, the timeliness was pretty good. Within 7-day time limit, eConsults were provided. And it took not a lot of time for me to do them. And then the impact on patient care, it seemed like the primary care physicians seemed to think they received good advice for a new or additional course of action, in addition to confirming what they were already thinking, and none of it was found to be not helpful. As well, there were several referrals avoided to come in, and the ones that were needed still came in, but they were not too many that needed to come in. So overall, it was thought to be helpful. So that just shows that you can have rapid access to child and youth psychiatrist, where there's a year-long wait list for the non-urgent referrals, many of which can be managed with eConsults, and that 69% of cases were referrals were averted, and 92%, like I said, thought there was good advice, and I was actually able to even provide some literature and evidence for some of the things that we were talking about, and that was found to be very helpful. On this slide, I just included some of the reasons I was consulted in the past few months. Most commonly, anxiety combined, like comorbidities, anxiety and ADHD, and how to start a non-stimulant like atomoxetine or Intuitive. Side effects on stimulants on someone that was on a combination of an antidepressant and a stimulant, so chest pain, side effect after starting stimulant, low mood, metabolic concerns, increased prolactin levels on risperidone. Some of the highlighted ones are ones that weren't that useful for consultation, and I will go over that list as well. So finding out, more about diagnosis of gender identity and how to do that was harder. And it wasn't severe enough for us to bring the person in. Generalized anxiety with panic attacks. Someone had not responded, initially responded to SSRI, but then became worse. How do you augment that? How do you manage anxiety with panic episodes? And then the highlighted one, there was a 13-year-old suspicion of sex trafficking that was not appropriate for the consult, but most of them were very appropriate. Gender dysphoria, but other mental health conditions, side effect of hypertension, heart rate on Vyvanse in a diabetic boy. And then another side effects of depression and anxiety on stimulants, long-acting stimulant versus short-acting, how to manage that. 16-year-old with depression and chronic pain, what would be the best way to manage that? And then some more reasons, 5-year-old with ADHD and autism spectrum, that's really to differentiate between them, how to move forward. And that was very helpful to kind of think through that algorithm. And non-response to one SSRI with anxiety, what do you switch next to? How do you manage oppositional defiant disorder in a 10-year-old with comorbid anxiety? And then the highlighted one, ADHD, oppositional defiant disorder in a 6-year-old with history of trauma, abuse, how to proceed, re-trauma. That wasn't that useful in the sense that It was a vague, not pointed question. And then the suicide risk in a borderline personality trait adolescent, previous suicide attempts, was not helpful either. They needed to be, the question was vague, they needed to come in. And in fact, that person did come in for already was sent to emerge, and that was the right thing to do. So just finishing off with the rest, 10-year-old with side effects to 2 SSRIs for anxiety and depression, how to proceed next. 18-year-old with disabling anxiety who did not improve on 1 SSRI, then started on venlafaxine, what to do next. And then 15-year-old with ADHD, depression, and anxiety who had no improvement on Strattera, what to do after that. 12-year-old with ADHD and sleep issues, which medication other than clonidine would help. So what are the problems best suited for eConsults? Like I mentioned already, starting a stimulant long-acting versus short-acting, switching a stimulant after a side effect on one, side effects on all stimulants, what to try next, sleep problems and ADHD, how to manage, ADHD and anxiety, can SSRI be started if already on stimulant? I included some websites that are helpful resources for ADHD here. And these are the CADRA, Canadian ADHD Practice Guidelines. It kind of walks you through the algorithm of treatment and what medications are approved, what is the algorithm, and also a lot of resources for parents, practitioners, and really helpful resources in there and tools. So this is another freely downloadable rating scale, SNAP rating scale, Swanson, Nolan, and Pelham for ADHD, which is very quick to do in the office. It's very helpful to get that done by the parent, send one off to the teacher when you have a high suspicion of ADHD, and then start stimulant right away. Continuing with what problems are best suited for eConsults. Let's say, for anxiety, 2 trials of SSRIs have been done, what to do next. If you have anxiety, ADHD, what to treat first. If some improvement in depression on an SSRI, full dose, what to do next? Do you switch? Do you augment? And if there's panic attacks with anxiety and depression, how do you treat? What do you treat first? So I did include more resources for depression and anxiety as well. This is another scale, freely downloadable, Kucher Adolescent Depression Scale. Very easy to do, just 6 items geared towards adolescents. I wouldn't do these in young children. Young children don't really present with depression very often. 13 onwards would be really good and scoring is simple. This is another rating scale for young children with anxiety disorders called the SCARED, Screen for Anxiety Related Disorders. This is for parents and children. If they're very young, only the parents do that. And it's also divides into social anxiety, separation anxiety, generalized anxiety disorder, very easy to score as well. And then finally, this is a tool for assessment for suicide risk, again, freely downloadable, which kind of gives you a risk factor algorithm to make a decision about how you would go through it. So finally, just questions not feasible for eConsults: suicide risk, suspicion of psychosis or mania, teen trafficking, which is a huge issue in our area. It's very big. Many services have to be involved, and nobody really knows what to do. It's a problem that everybody's kind of tackling together. And so it's a tough one because they don't fall into any one category. But if there is within that psychiatric issues that are very prominent, then it makes sense to ask the question around that. Child protection issues, autism spectrum disorder assessment, gender dysphoria and its treatment, self-harm and previous suicide attempts, severe aggression. Those would be most of them, the suicide risk, psychosis, mania, severe aggression, self-harm. I mean, those would be going to the emerge. The other ones need a lot more, but if you can pick something out that's more targeted within that, that would then be a good question to ask within the consult. And if the background is given, then maybe me looking at it, I could say it needs a referral for us to do a thorough assessment. So I'll just end here with my information. Happy to receive calls if needed. And I'm very excited to get more consults. I love doing them because it is fast, it's easy, and it's kind of also keeps me on my toes. Thank you.
Great. So thanks very much for that slide overview. So if you want to stop sharing your screen, we can open it up for questions with the group. So maybe I'll just jump in to get us started. So it sounds like many of the questions that you're easily able to manage have to do with medication management, ADHD management, and anxiety. What kind of information is it helpful to you to get when seeing that eConsult from the primary care provider?
So I think just generally how long it's been that the person has been struggling, the general questions, how long, what's changed recently, and what are the struggles with the parents and the family situation, and what medications have been tried, if any, and what is the impairment, right? How are they doing in school, at home, with their peer group? Just kind of getting that information is really helpful. And often, doing these rating scales, like let's say there's anxiety in a kid, doing the scared and kind of attaching that with that would really helps hone in on the severity of the symptoms.
Right. One of the questions in our chat says, how long on average does it take you to complete a consult?
So I included that in my data, 10 minutes on average.
Right. And your response time, so if someone's sending an eConsult today, when can they expect to receive a response from you on average?
So on average, it's done within the week. I usually do it right away, unless it's, if I'm off or something. So within 2 to 3 days, I'm able to finish.
Yeah. I would say across all of our specialties, the expected response time is up to 7 days, but we find on average it's between 48 hours, depending on what's going on. I would say 48 hours to 5 days, very common amongst all of our specialties. So, any other specific questions in the chat, or if people want to raise a hand and have a question for Dr. Khalid-Khan? So maybe another takeaway is, it sounds like you had a lot of information there about pathways and guidelines and tools, which you readily include within your responses, which is fabulous. Do you have instances where you figure out that you need to see the patient? Are there things that you can do through the eConsult that help prepare that child or adolescent for their first visit with you?
Yes, I mean, I think unless the person is being described as imminently suicidal, then really we just need to get them going. But let's say there's clear indication of depression, safety is not an issue, there's going to be a little bit of a wait. Let's walk through what are the things going on. Have they tried anything? Let's start an antidepressant, because there may be a month wait to get in, because it's not deemed urgent. We do have an urgent clinic. Again, they also have their criteria, so they may not be accepted. So let's say that's an issue. So starting an SSRI and kind of walking the primary care provider through that would be really good. And often with anxiety and panic attacks, they may have to what I usually tell them is start an SSRI, but also a low dose benzodiazepine, usually clonazepam, only with young people if the parent agrees, really, really low dose, 0.25 once a day, just to get them going. And then we taper it off later. So it really, if the rating scales are done and a thorough kind of look through it, it helps. It's helpful to kind of take the person from there to then do the rest of the assessment when I see them in person.
Interesting. Right. And as you say, there might be a waiting period, even if they need to be seen. So how can you assist in managing the patient during that waiting time?
Yeah, I mean, I think within that time, what we did during the pandemic, for at least for myself, I offered 15-minute sessions to primary care docs to manage, and we selected the referrals. If there was a question about medication or treatment of common disorders, just offering them that time and then walking them through, because there was a time where it wasn't even a 1-month wait. We couldn't really see people. There was a long wait and there was only one person really dealing with everything. So let's start this. What are your questions? What are some things you can anticipate from the parent? I did find that some people are very comfortable and some people are just not comfortable because of they just said right up front, I'm not comfortable. I've never treated 15-year-old with antidepressant. So then it becomes kind of tough if they're just not wanting to do it, right? So that's becomes a barrier. But I would love it if 15-minute consults to even in person kind of talk the person through, starting it, because I think some of these things just need practice, and then kind of send for higher level care later on.
And when talking to other specialties, often there's been a back and forth dialogue too with the primary care provider when you're talking about patient management. So they might reach out by eConsult with an initial question. You might talk to them about medication management on the patient, and then that dialogue continues. So it's not just one eConsult and then you're on your own primary care provider. There's ongoing support. Is that the same for you?
Yes, absolutely. So one example recently that came to mind was the one I included about risperidone and a child having a high prolactin level on it and developing side effects to it. And so the idea was, but it was effective for anger outbursts and really had a major positive effect. So then you're stuck with that. So how to manage that was a back and forth of 3 different times of consultation around that issue, and ultimately it resolved really well. The feedback I was given, just giving 3 different options that the primary care provider could do with that. Either they could taper it off, or they could add another antipsychotic like Abilify that would actually is not going to affect the prolactin level, or taper it and then add it and then keep the 2 for a little bit to see how that works. So yes, that happens. And it's actually a great to have that, because that you're building capacity and it's fun. It's good.
Excellent. So it sounds like it's not just, I've got a patient, I'm wondering what to do, but it's also a level of skill building and building comfort in sort of managing these patients, whether they need to go on to see you directly or whether you're sort of working as a team to look after that patient.
Absolutely.
Great. So final reflections on eConsult and how you've incorporated them into your practice?
Yeah, I mean, I think the best thing is, they're not, although we are a tertiary care center, obviously, and we do, I think a lot of the consults come within the Kingston area that are appropriate, because our area triages them and knows, the system. The ones outside of Kingston, Belleville, Brockville, especially Belleville area and surroundings, they are often not appropriate level of care for tertiary care to bring in. They are more appropriate for, let's get you just started with enhancing capacity within that service. They don't really need to come in. they have enough services in the region, but I'm happy to kind of help you along. So I think that's where often is where, there's an issue where they're just not the right severity to bring in, and yet they could get treatment pretty quickly with the vetting of the eConsult. Right. And if you're managing a heavy duty case, in between that, you can ask questions as well. Here it is, this complex, what do I do? I know there's a wait. How do I manage in the middle, right, of doing that? So, and you know what, any question is good if you're building comfort. We can just say, what is it, kind of walk the person through as well, because it is a practice, right? For anyone that starts using it, you got to build comfort with doing eConsults.
Right.
Same as myself, right? So if you don't use it, you're not going to get comfortable. So I think not overthinking it, just going with it and see what happens is what I would advise.
Super. Well, thank you for being part of our eConsult series. We really appreciated you joining us this morning. Okay. And for those, this is the last in our 8-part eConsult series. So we'll be sending out a survey shortly for our participants so that you're able to collect your credits through either the Royal College or the College of Family Physicians. Within that survey, you'll see we're asking about your interest in future eConsult webinars, because we'd be happy to continue to run the series. Thanks everyone for joining us this morning. Take care.